afternoon and welcome to our SASOHN meeting, July the 29th. Our program is, we've got a service provider that's going to have talk about introduction to risk assessment, and then we've got our back to basics speaker. And we will do it in the same format that we've done it in the past, where we first have our presenters, and then straight after that we go on to the agenda and portfolio presentations. We've received a few apologies, as was indicated on the WhatsApp group, and our secretary will minute those people that apologize. So without further ado, Dorothy, can you unmute yourself? Johnny, do you see the speaker?
I can see Dorothy, but she's not unmuted.
I can see the slides.
Good afternoon, Dr. Itumeleng. Welcome. Yonika, you can do the introduction.
Oh, sorry, I don't. It's with Dorothy.
I think Dorothy's having a glitch there when she said on the WhatsApp group she's struggling to unmute herself.
It's okay. I think I've got a slide which can introduce me. It's fine.
Okay,
the next slide.
Second. Dr. Itumeleng, sorry that we can't introduce you, but you are very welcome to start with your presentation. I'm going to just unshare.
Okay. So you want me to share on my end?
Sure. You can kick me off if you want.
Okay. Let me do that. You'll just tell me when you can see it.
Sure.
I can see your slide, Doctor.
This is the slide from you, so I've got to put in my own one. There we go. And just let me know if you can see. You can. And then
we can see it.
The next one. There we go. Maybe let me do my video for initially. Are you able to see the video as well?
Yes, we do. Thank you very much.
Okay. All right. Thank you so much, and good afternoon to everybody. Itumeleng, as introduced. So, very short bio about myself. I'm the occupational medicine specialist at the Division of Occupational Medicine at UCT, and currently also running the E16 Occupational Medicine Clinic. So it's great to meet all of you virtually, and looking forward to your referrals and engaging on some of your more complex clients that you'd like to send through to Groote Schuur Hospital. So I've been asked to do an introduction to health risk assessment, and the approach that I thought, similar to the back to basics, is to really just focus on a step-by-step approach. Many of us in the audience would have had some experience with health risk assessments, and I'm hoping that this would be a refresher, but it also might touch on new aspects that you would like to focus on in terms of enhancing your own risk assessment. Okay. I think in the interest of bandwidth, I'll switch off my video and then switch it back on again at the end. But in terms of what will be the presentation outline, I will be focusing on, what the health risk assessment, where does it fit in terms of the spectrum of occupational health, what is it, and why do we do it, and more importantly, how do we do it and who does it as well. So at the end of the session, you should be able to conduct a qualitative health risk assessment and be able to report your findings. So where does the health risk assessment fit in? So I just thought, just as a reminder for everybody, to include here the organizational health or occupational health overview. And part of the work that you probably all are involved in would have to do something with regards to risk management. You might be involved in support services such as an on-site primary health care provision, or you may be involved in rehabilitation. They certainly might be in the third column, some health promotion that you get involved in, wellness days, chronic disease management, or incapacity or disability issues. And some of you might also be involved in strategy and being involved at that level of the organization. The focus of this lecture, though, will be on the first one, which is the green box, what that focuses on risk management. And part of the risk management of an organization is the health risk assessment, which is what we'll be speaking about. But of course, some of you and colleagues in the health and safety space might be involved in safety management. You might be involved in medical testing or medical surveillance and recruitment practices as well. My focus, as I've said, will be on this block. Okay. And of course, just as a reminder, in implementing comprehensive occupational health programs, it's important to position what we're going to speak about in relation to the various protective, the various measures that we have in the workplace. And what we've got here, of course, on this end of the slides, or in the green, are the more proactive measures, right, that minimize the likelihood of adverse incidents happening in the workplace. And of course, that would include primary prevention. And the objective of primary prevention is, of course, to prevent exposures. And we do this by doing a thorough health risk assessment and, of course, putting risk mitigation in place. However, we also get involved in secondary prevention, like all of you, where the aim really is to prevent progression to occupational illnesses. And we could perhaps be doing medical screening, audiograms, etc., periodic medicals. However, we are also, as health professionals, involved in the more reactive measures. And this would be, of course, tertiary prevention that speaks to preventing progression to incapacity or disability. And this would involve, being involved in rehabilitation, redeployment, accommodation, etc. Those are other topics for other days. For what I will be focusing on really today is focusing on this issue of primary prevention through doing a thorough health risk assessment. So what is a health risk assessment? So the National Institute for Occupational Health, NIO, describes it as a careful evaluation of or examination of what could cause harm in the workplace. And you really do this so that you are able to decide whether you have taken enough precautions to prevent serious injuries or diseases from happening in the workplace. Okay. Others describe it as a systematic evaluation. So there must be a system that you use, systematic evaluation of hazards in the workplace, and an assessment of the degree to which they pose a risk to employees. And of course, usually also includes steps to mitigate the risk where it is identified. And as a reminder of the concept of risk, hazard and risk in occupational health, just as a reminder that I think of a hazard as any agent that has the inherent capacity to cause harm to health. And when we speak about the risk, however, there's much more to just the hazard, right? So it is the likelihood or the probability of harm occurring after exposure to that specific hazard. And the way we generally calculate risk is using a multiplication calculation, where you would multiply the likelihood of exposure to the hazard multiplied by the consequence or the severity of the consequence. Okay, so effectively, where likelihood is the likelihood of exposure to the hazard, and multiplied by the consequence of an event or adverse outcome happening. Therefore, a health risk assessment requires an understanding of the health consequences of different hazards, and also, of course, you also need to understand how exposure can occur in different settings, be it inhalation, dermal absorption, etc. So in summary, if we put all of them together, on the one hand, risk means a combination of the likelihood of an occurrence and the severity of ill health or consequences caused by exposure to that caused by exposure to that specific hazard. A health risk assessment, therefore, means the process of evaluating the risks to health arising from hazards at work and determining the appropriate measures for the risk control. Risk control means measures to eliminate or reduce the risk associated with the hazard. And some of you might also pick up on the word risk management. So that means the total procedure that is associated with identifying a hazard, assessing the risk, putting in place control measures, and then reviewing the outcomes. Okay, so this is just an example of the process of risk management, and it would start here, classifying the process and work activities, hazard identification, risk evaluation, risk control, and then risk reevaluation, implementation, and then recording the activities that had been undertaken. Okay. So why do we perform health risk assessments? Of course, it is illegal. It's for legal compliance, and we will come to the legislation just very briefly. But it also is, has a component of a moral obligation of, morally making sure that the workers are that hazards within the workplace are identified and the risk associated with them is determined, and that, of course, morally, that you ensure that the controls that need to be in place are in place to ensure the protection of those workers. Okay. We also perform it, as I said, to understand precisely what hazards are present and if and how workers are exposed, right? So it might be that workers are not exposed, but if they are exposed, we need to understand how is it that they're exposed. It allows us to grade exposure risk to prioritize interventions and control measures. And it also helps us to determine actions that are required to manage the risk as well. Similar to the second talk on ionizing radiation, it will inform you. So what you find on the risk assessment will help inform the medical surveillance and the fitness to work standards that are required in the workplace. In terms of legislation that requires health risk assessments to be performed, the Mine Health and Safety Act is one example, and the Occupational Health and Safety Act is another. And in many of the regulations that have been promulgated under the Occupational Health and Safety Act, it is quite clear that there is a need for a risk assessment to be done, and it even outlines the steps or the components of the risk assessment that should be included. Okay, so the hazardous chemical agent regulations, hazardous biological agent regulations, lead regulations, asbestos regulations, the noise-induced hearing loss regulations, or the noise exposure regulations that are the more newer ones, all of them make reference to the need for a health risk assessment to be conducted, and hence the importance really of this talk and making sure that you feel competent in doing the risk assessment. In terms of who performs the health risk assessment, so what I would really advise is it is better to be done as a team. As the occupational health nurse, you might be the one leading the risk assessment, but in whatever plant that you find yourself in or work setting you find yourself in, if you do have an occupational medicine practitioner, it would be great to have them with you on that walkabout. And in of course, compiling and writing the risk assessment. If there's a safety officer in the area, if there are certain engineers that are stationed in specific areas, and if there are occupational hygienists that are there in the company itself, it'll be great for you to call them and very useful as more eyes are able to identify more hazards in the workplace, and you're also able to discuss what your thoughts are about the risk ratings that you'll be giving as well. So if possible, arrange your risk assessments at a time when most of the team members are there as well. Okay. Now, in performing a health risk assessment, there are very clear steps that should be followed, and I've just named them as step number 1 to number 6. And the first really relates to defining the extent of the assessment. Then we will identify the hazards during a walkthrough, and even in terms of gathering information. You need to understand the exposure. You need to calculate the risk. And of course, you need to also consider risk mitigation strategies and other actions. And of course, at the end, what they really do require in each of these companies that you'll be in is that you need to complete a report that you can then produce and give to the employer. So let's go into step 1. So the first step is you really need to define the assessment. So you need to, in your own mind, be very clear as to define which process or activity is being assessed. Are you evaluating a specific person that has developed an occupational disease and you need to do a risk assessment in relation to that person? Are you evaluating a specific machine that has been newly bought in the company? Or are you required to evaluate a specific area? So if you're in a hospital setting, are they requiring you to do a risk assessment in the boiler house or in the laundry or in the oncology ward or radiation ward? So you need to be quite specific as to what the scope of your, so to describe what exactly, you'll be focusing on. Now, you also need to understand for yourself whether, is this a scoping visit where you're just trying to identify what the issues are generally, or is it a full risk assessment where you have to identify all the various hazards and risk them and determine a risk rating for them. And of course, you need to also find out for yourself, are you going to do a risk assessment in a new area, or is this an update of a previous HRA? So if it's an update of a previous HRA or HIRA, you need to get that one that was done before to be able to also inform how you plan for the for the current one that you are involved in. Once you've assessed what the the activity that you're being asked to assess, you've determined that, you then need to also understand what is the expected outcome. Do they want a full report on the risks that are there? Do they want you to develop a plan for medical surveillance? Do they want you to suggest controls of the various hazards and how to do it better? So find out exactly what is it that what is the reason for the what is the expected outcome of you doing this exercise. And also think about how you'll get information, how long it will take, and who will complete what tasks. Particularly if you are going to be costing this as an occupational health nurse practitioner, you need to be able to have all of this knowledge or insights for you to be able to quote and to provide cost estimates accordingly. Okay. So normally the first step in the hazard identification is a walkthrough survey of the plant or the factory or the area. So try and avoid doing only desktop risk assessments. Rather, use the desktop moments to gather all the information, but you still really need to go into the workplace itself, do a walkthrough of the plant or the factory or the area. And of course, as I said before, you do the walk, you will need to have an idea of the type of work or processes that are there, and hopefully have a chance to do your own research as to what are the risks associated with the type of work that you're going to be seeing. And I would advise you to go onto the Health and Safety Executive, so HSE websites for the UK, or CDC, NIOSH in the US, or NIO in South Africa. So these are good websites where you could be able to find details on different industries and what you need to be aware of before you go into these sites. You obviously need to also prepare for the walkthrough, right? So you need a clipboard with note paper and pens. Ask for a list of chemicals if it's a chemical process plant, for example, chemical processing plant. You need to also ask for a site map, which you can use to mark areas of concern as you go about. Okay, it's of course important for you to set a good example. So, this is, for example, when we went to SASCO and the PPE that's provided, you need to use that and be in appropriate clothing as they would have provided you, and use the appropriate PPE depending on the industry you're going into. You need to follow the instructions. So if there are walkways like these, for example, it's important for you to follow and use these walkways and not be found wandering on the sides. And of course, you also need to have, present yourself professionally, and of course use the correct terminology in the industry, which really does impress them. Okay, and this just shows that terminology matters. This is just an example that I had where people were talking about the lathe and the lathe and the lathe, and I kept thinking about this lather, which is the soap one. However, what they were speaking about was actually this machine, right, which is a machine that's used for cutting, grinding, etc. So knowing what a lathe is as you go into that industry and do the risk assessment, that shows them that you have insight into what they're doing, and an interest in what they're doing. Okay, so the second step, once you've done that, the second step is, of course, for you to identify the various hazards. And my advice there is really to prime your senses. Sight, observe what the processes are, the environmental conditions that the workers are in, observe what control measures are there, and how and see if you can determine for yourself how effective they are. Smell, so many chemicals are also present as gases or vapors, and some particularly cannot be seen. So you need to, if there's a specific strong sweet smell that you are smelling in a boat making factory, you might want to find out what is the sweet smell that I'm encountering. Is it styrene? What is it that I am potentially? Is it benzene, or what is happening? Okay, and hearing, obviously, you need to listen. So noise is one of the most important, significant, and ubiquitous hazards in industry. And I've just put a picture here from Engineering News just in 2024, which showed noise-induced hearing loss is one of the priority conditions in the mining industry right now. And this would be noise in factories, could be noise in a plantation, a forest and or cultural sector. So just listen to what you hear. Touch, of course, you may be able to feel vibration, heat or cold. And of course, taste, this is not to say eat the chemicals, but if there are some airborne contaminants that might cause a taste in the mouth, like spices or sweet flavors, you need to note this as well. Okay. While I say this, it is important just to be aware of false impressions. So hydrogen sulfide, for example, has got a rotten smell, but carbon monoxide doesn't have a smell, and benzene has a mild to, or sweet smell that you need to just be able to identify. Okay. In doing the walkthrough, try to walk through the factory in production process order. So, for example, if it's in this factory, you will start doing your walkabout from the receiving area, where the raw materials are kept, where there's batching happening, blending, packing, and then dispatch. So this is if it's a spice factory, for example. If this is a scrapyard, you would say, delivery of the scrap. There will be shredding. So you would go to the area where there's delivery of the scrap metal, where there's shredding happening, where there are furnaces or smelting, and the rolling mill to create, or rolling the mill to create the rebar as well. Okay, so as you can see, once you understand what the processes are, you can then go do specific targeted risk assessment for this area, this area, this area, this area, and then be able to have an overall picture. So in terms of the physical walkthrough, it's also important for you to consider, of course, first impressions. If you look at the images that I've put there, what is your impression of the, how do I say it? What is your first impression of the housekeeping in this plant? So this was a walkabout which we did in an individual who we suspected of occupational asthma. And as you can see, the company didn't really even try to, in some cases, you might find companies try to make sure everything is clean before you come. But in this case, it wasn't the case. Are you able to unmute and just describe what you see um, in this image? Yeah, I think maybe you might be muted on our end. Is there someone?
Doctor, I see step 2, physical walkthrough. Consider the first impressions and the work area by area and the housekeeping is terrible.
Yeah, what is the concern? What is your biggest concern?
They can trip, they can shock, they can get injured.
Yeah, and if you look at the chair here, I mean, they're working with a lot of wood dust, and already this tells you that whatever mechanisms they are using to clean or to remove the wood dust are not working, because just look at how filthy and how dosed with dust this area is. But you can see it throughout there as well. Okay, all right. So perfect. So those are some of the first impressions that you will have, whether or not is this place neat and clean, or does it have very poor housekeeping, as you can see in this case. And already that should be making you think in the back of your mind, if the housekeeping is this poor, what about all the compliance to the other the other regulations or the other expectations as well. So you also need to obviously look at general safety issues such as signage, fire systems as well. Are these in place? And if they're in place, are they appropriate? And of course, you need to look at the provision of control measures and personal protective equipment. So I often ask them to bring their personal protective equipment, and you'll see that even in noise areas, people will still be looking around and trying to look in the cupboard to find where their earmuffs are, or where their hearing pieces are. Okay. And the advice, as I said, is work area by area. So you need to jot down the obvious hazards that are there. You need to indicate the pattern of exposure. Is it intermittent? Is it continuous? Is it frequent? Is it seldom? You also need to consider work practices such as manual handling that you could see around there. And very important for us is that we need to consider susceptible people in that environment. So pregnant women, older workers, disabled workers, these are all individuals that you need to consider in your walkabout as well. Okay. So in terms of the hazard classification, this is both for health hazards and safety hazards. I've just combined them and really just revision for many of you. So there are physical hazards, chemical hazards, biological agents or biological hazards, ergonomic hazards, and psychosocial hazards as well. Okay. And if one was to look at the physical hazards, so this would include noise, vibration, which is segmental, or segmental meaning if you exposed to vibration using a rock drill, for example, which exposes much of the vibration to the upper arm, right? So it's segmented, it's in a specific region or area, or it could be whole body vibration. Think of the forklift drivers and the long distance truck drivers. Light or darkness, temperature, and could be extremes of heat or cold, and electromagnetic fields, poor ventilation, working at heights, which may um, uh, increase the risk of slips, trips, and falls, moving machinery, unguarded machinery, and vehicle collisions as well. Okay. So we had a risk assessment at a forensic pathology mortuary, and one of the issues were the risk of vehicle collisions, both when the families and the undertakers came to collect bodies, and because they were collecting and reversing in a very narrow area, and of course vehicle collisions on the field when they're collecting the body of the deceased. Many of them have to do this on the highway, etc. So there are vehicle collisions, possible vehicle collisions that could occur. So you would need to be able to, if you do it step by step and area by area, you'd be able to pick up that collisions is an important one for your setting. Okay. So that's the physical. Then you've got chemical hazards. So there, as you can imagine, thousands of them, right? And we generally will classify them according to their physical state. So there are some chemicals which are solid, some are liquid, like the detergents that are used in the hospitality industry. Some are gases, think of even in healthcare, anesthetic gases, etc. Vapors, dusts, mists, fumes, and fibers as well. Okay. In terms of the biological hazards, they are quite a number, but you could divide them into bacteria, fungi, viruses, or animals, and ergonomic hazards, which include awkward posture, repetitive movement, lifting and carrying movements at the extremes of reach, and poorly designed workstations. And psychosocial hazards, there are many, and these could include issues around work organization, antisocial working hours, difficult interactions, workplace stress, bullying and harassment, excessive workload, lack of job control, violence in the workplace, etc. And the way in which you would control for these, of course, is to, you've seen this picture at the beginning of my talk, which was put up by the colleagues. You would use a hierarchy of control measures where the best would be for you to eliminate the hazard, so physically remove the hazard. If that's not possible, then you need to do substitution where you replace the hazard, or you put in engineering controls where you isolate the hazard from people. And you could also put administrative controls which change the way in which people do their work. And then finally, you would recommend personal protective equipment, which is considered the least effective because it does really require increased supervision and participation is required, and non-compliance is very common, an issue. So this is just an example, just to show how effective the hierarchy of control is and how important is it for you to be quite familiar with it. So the hierarchy of control measures, this was just what was used at the start of the COVID-19 pandemic, right? So in 2020, when we didn't even know much about the pandemic, but the Department of Labor was able to put these in place where, they looked at engineering controls, including the building issues like negative pressure, isolation rooms, ventilation, devices, and even the in terms of the administrative controls, it was quite rigid in terms of what they are advising. They advised implementation of policies and procedures, health protections, and enhanced training, and this would include occupational health and safety training, incident training on social distancing, hand and respiratory hygiene. And health protection will include making sure that there was access to employee assistance programs, vaccinations, medical surveillance, and mental health support as well. And of course, lots of training. What is this virus about? What are the hazards and the risks associated with it? What control measures are there in this workplace? What PPE is there? Incidents, and obviously advocating for general good hygiene. And then PPE is the final one. They're very clear that it should not just be PPE given. You need to make sure that it's the correct fit, it's the correct type, and the usage and maintenance and disposal of it is dealt with as well. Okay, so this just to give you an example of how you would use the hierarchy of control measures in whatever workplace you find yourself in, and or whatever situation you find yourself in where you're doing a risk assessment. Okay. And as I said, in terms of the engineering controls, the most common one is improved ventilation. So extraction, local exhaust, dilution, or natural. And of course, you've got administrative controls, which include training and information, safe work procedures, and work rotation, commonly forgotten, but that's an important one, work rotation. And then finally, PPE would include overall safety shoes, gloves, goggles, dust, respirators. And the various respirators would be depending on the industry that you find yourself in, okay, and the bodysuits as well. But in doing the walkabout, I would also just advise you, particularly if you are new to it, to have a clear checklist that you could use. This is just an example of it. And in It will explain to you what you should prepare before you go onto the walkabout, what you should prepare after the walkabout. So in this example, this is the one that we use at some facilities in the Western Cape, for example. It will say, are there previous risk assessments and hygiene measurements in this place? If they are, you need to obtain them. Are there any previous injuries, incidents, occupational diseases in this workplace? Because that tells you a lot about your medical surveillance program as well. You need to know what the people who are working there. So the list of the workers, or the different job categories at least, and how many in each you have. And you would also be able to just look at the processes and the work tasks performed during, including the exposure duration or shift times. And when you do the walkabout, obviously you will look for the physical, the chemical, the economic, mechanical, etc. Okay. And importantly, you need to really look at the type of control measures that are there, such as ventilation, isolation, substitution or elimination, training, and air monitoring as well, if you've got evidence of that. If there are any written safe operating procedures, they need to give those to you, because you need to be able to determine whether or not are they being followed. And if there's any biological monitoring on vehicle examinations that are required, you would also need to make sure that you've got this information on hand. Okay. So once you have done that, you obviously need to gather the information. So you need to ask for information such as inventory or registers of substances that are there. You need to ask for the safety data sheets and other sources of relevant information. It's important for you to understand the nature of the processes that are there, particularly if you're not familiar with the industry. So you really need to spend a lot of time trying to understand the nature of the processes and the form of the substances that are used. Is it vapor? Is it gas? Is it liquid? And also, as you do this, you need to also think about the routes of exposure, inhalation, skin absorption, ingestion, and the associated health effects. Okay. In terms of the sources of information, you've got a number of people that you can talk to. So the workers are obviously the better options, because they will tell you exactly that, I use this specific chemical for this. No, that one, that PPE we've been given, but we don't use it. So they give you quite a good sense of information. You obviously would need to do manager interviews to understand their work practice and controls. And of course, you need to obviously interview, if the company itself already has medical and safety staff, you can ask them about injuries, occupational diseases, patterns of disease, because this will give you a sense of where the pressing issues are. And of course, if there are any internal company documents, such as standard operating procedures, safe working procedures, or past environmental results or risk assessments, they need to give these to you, because you need to see what is the difference now versus previously. And if there are any government and international standards for exposure limits, you would also include them. Okay. Right. So that's in terms of the sources of information. And the other important thing, of course, now is for you to appreciate the exposures. Okay. So you've prepared yourself. You have determined that you're going to go into the workplace, and now you have to understand the various exposure. Okay. And this is the step where experience and practice does make a difference. And hence, I had been encouraging you to have, particularly if you're new at this, to have other older colleagues who've been, or more experienced colleagues, to assist you, because you see so much more differently when they pick it up than when you potentially miss it. Okay. So it's also important to look up recommended operating practices and precautionary measures for specific hazards, particularly when the company is not forthcoming with this as well. And remember, exposure will differ depending on the concentration or the dose of the hazard, the duration, the physical state that it's in, and the control measures that are in place. Okay. So when we are quantifying or measuring exposure, we normally would do this after the initial qualitative health risk assessment, if there's a suspicion that exposure is high or if required by legislation. Okay. So in South Africa, measurements of exposures to noise, dust, chemicals must be performed by an occupational hygienist who's registered with the Department of Labor as an approved inspection authority. Okay, so different sampling strategies can be used according to the reason of the survey, and that's the great thing about having an AIA approved hygienist next to you when you're doing this this work. Okay. So then, close to ending, the remaining big things, of course, now that you understand the hazard, is to calculate the risk. And there are various tools that you can use to calculate risks. And however, I must say, all of them have got the desired outcome, which is they want to help you categorize risk to health from the different hazards so that they can be actioned appropriately, and also that we can focus on specific, areas early on. So in order for you to calculate the risk using the matrices, there are various versions that you can use. The simplest one that I advise you to use is the simple 5x5 table, where score of 1, you score 1 to 5 for the health effects or the consequences, and you also score 1 to 5 for the likelihood of exposure. And you then multiply the two to then get a total risk score. So you don't add them, but you multiply them. And some add an additional step for probability of exposure or possibility of disease, which we are not focusing on now. And this is what the risk calculations will look like in terms of the Malaysian model. You would, if this was your patient, you would look at the likelihood of exposure. Is it remote? Is it conceivable? Is it possible? Is it most likely? And of course, the severity of the severity of the health consequences. Will it be catastrophic, major, moderate, minor, or negligible? Okay, and depending on what your assessment is, if you were saying that moderate severity and possible possible likelihood of exposure, so that would be possible likelihood of exposure. So you would go down here, and you would then merge. You would let that imaginary line meet with the moderate exposure, which would then result in a moderate or medium risk rating. Okay, which is very different if the likelihood of exposure was a 5, was quite high, and the severity was moderate. It would then put this into a high risk practice or a high risk rating. And in calculating the risk, this is the Malaysian model, a very simplified version for you to be able to get to the concept. So if one is looking at the exposure rating or the likelihood of exposure, if there's no exposure or no priority, you would generally give a 1. But if there is moderate exposure, or 51 to 100% of the OEL, you would normally give a 3. And very high exposures, which normally are 3 times of the OEL, the occupational exposure limit, you normally would give a 5. And in terms of the health consequences, if the 1, if they are reversible health consequences, right up to severe health, where there are severe health effects after repeated or prolonged exposure, or very serious health effects. And very severe irreversible health effects would be like a 5, for example. And clearly the consequence there is quite dire because it's life-threatening. And this is just an example of how you would put the likelihood, which is the exposure rating, and you would then merge it with the consequence hazard rating, okay? And where the two meet. So if it's a high likelihood there with a consequence that's number 4, it will meet at this point, which is the 4 multiplied by 4, which gives you 16. And anything in the green is a low risk score. Anything in the orange is medium risk, and anything in the red is quite high risk. But what does this risk rating help you with? It does help you in terms of then thinking in your own head what my next steps are. Okay, for example, if you've got a risk rating of between 15 and 25, what it says to you is that there's strong potential for serious injury or disease and major damage to the company property or reputation or equipment, and therefore the action is immediate. Corrective action needs to be taken. If you've got a risk rating of 5 to 12, there is corrective action that's required and a planned approach. And if it's really a green or 1, there's low potential for injuries or disease, and just keep an eye on it, keep an attention to it. And this is just another one modified from Dr. Greg Q, which is much more just showing you how much more complex it can become. But I would be fine with you just sticking to this simple algorithm, which is I still use and many others still use. And then the other final steps include identifying actions based on risk. So where there's an identified risk to health, you need to specify the steps that are needed to take effective control and to improve things. And of course, this is an integral part of the assessment, and the assessment is not complete without this particular component being addressed. And as I said, in terms of the actions, they will really also depend on what the risk rating is that you have. Okay, and I've just indicated that there. Of course, you need to reduce exposures using the hierarchy of control measures. You may need occupational health, occupational hygiene sampling based on the risk findings. You may need to start putting in certain medical surveillance in place or biological monitoring, and determine a review period. And then finally, you need to complete the report, so which demonstrates compliance with legislation and also helps drives the actions that you are requesting or that you are recommending, and also helps you in 2 years' time when you need to redo it. It helps with that later review where you can see whether things have been addressed or whether things have just been left as usual. Okay, so just in ending. And now I'm left with literally 10 minutes. Just wanted to give you just examples. So this is an example of a boat making factory. And what we find is that there were physical, if you look at the first column, there were physical, chemical, and ergonomic hazards that were there. And specifically, in terms of the physical hazards, they picked up on noise, and it was measured at 90 decibels. And vibration, they noted that there was whole body vibration in the forklift drivers, and therefore the exposure rating for the noise was 4 and the vibration was 3, and the health effect, the worst being noise-induced hearing loss, was given a 3, and back pain was given a 3 as well. And as you can see, the risk score that you then get is this 4 multiplied by the 3, which gives you a 12. Or 3 multiplied by 3, which gives you a 9. Okay, and then being a 9, you would have to go here and see. Okay, so a 9, where does a 9 fit in? A 9 fits in here, 5 to 12, which is tolerable. Okay, so in terms of the chemicals, styrene was another one, and it was ubiquitous in the factory. It was everywhere in this boat making factory, so they give it a 5. And the health effects, neurological and asthma, was a 3, and the risk score was a 15, which is quite high. Okay, and the advice there was that they needed to do an urgent assessment of the ventilation and the work methods, and also wear respirators as well. Okay, and similar to benzene. So benzene was low because in the exposure was very rare, like once every 3 months or something. But obviously the health effect is quite severe. You could develop a leukemia. However, the risk score based on the exposure rating and the health effect rating was low. Okay, so sometimes you might see that, and don't be alarmed. And ergonomic issues, they've indicated repeated bending up to 10 kg boxes performed for 3 hours, and standing for greater than 5 hours. So that was rated as moderate risk, and recommendations were training in safe lifting, consider a hoist or equipment to lift, and ensure appropriate footwear is made available, and allow rest breaks. And so it goes. So this is a steel factory one, different way of looking at things, but similar in the sense that there's the work activity, there's the hazard, there's the event and consequences, the risk control measures that are there, the justification and likelihood, and they put here likelihood multiplied by severity equals to risk. Okay, and you can see there 5 times 2 is 10, 3 times 3 is 9, 4 times 5 is 20. Additional risk control measures, and then they even have a space here for re-evaluation. Okay, so they clearly expect in this risk assessment that once you've done and reported, you must go back and re-evaluate, and they've got the people's name there and any other comments that need to be made. Okay, and then this is my one that I had done, and it was at the mortuary, as I said, and one of the important hazards that we spoke about was biological exposure to HIV, and as you could see, I wrote there what processes are being performed. So there's direct contact with the deceased patient, and broken skin sometimes. Who's at risk? The pathologist, the forensic pathology officers, the cleaners. So you need to understand all the different levels to be able to identify these people. And how are they exposed? They're exposed, during sharps when they are used in the dissection of the deceased bodies. Sometimes there are objects within the body, like bone fragments or bullet fragments, that then pose a risk to them as well. And the current controls, they had, for example, pre-autopsy whole body radiography to locate sharps and bullets and other irregular bone fragments. And of course, they also had simple things like sharpening, a sharpening stone for their knives and dissection kits. And there were administrative controls such as sharps containers available, good biohazardous signage, and you could also have, they also had an emergency eye wash available in the dissection area. The risk rating was medium. So when you look at this medium risk rating that I have put, what is your concern with it? Anyone?
Doctor, it looks like it actually should be high and not just medium.
Yes, fair enough. But what would make you think high? What should I have put in? This was one of my first risk assessment, and I put it here because obviously as one learns over time, you then learn that there are things that I should be improving. So does it tell you anything in terms of medium as to how I got to the medium?
No, it doesn't.
It doesn't, right? So what would have been useful for you to be able to even determine whether I correctly graded it, and maybe I should have rated it a high, is that I should have been giving you a sense of what is the risk rating number that I got. So was it a 3 multiplied by 3 equals to a 9, or was it whatever, 2 multiplied by 4, then it went to an 8, and therefore it was a medium. So you would need that kind of information, similar to how these guys have done it, right? Where you need to know for likelihood of exposure, what had I given? Was it a 3? And in terms of severity of the exposure to that HIV, to the HIV virus, for example, what did I give? And then obviously then it will determine what this risk rating is. So if I'm saying it's a yellow, I need to be quite specific as to how I got the risk rating. So that is important just for all of you to be aware of in your own work that you do. And then in terms of recommendations, I gave recommendations such as needle stick injury, sharps, and splashes are common. So they need to needs to be better attention looked at the unsafe working practices. They need to look at use of needle and syringe instead of use of needle and syringe instead of safer options such as safety hypodermic needles, and blunt needles should also be avoided. And sharpening stone, they could procure more of those, and also make sure that they don't put a lot of the equipment next to the bodies, because some of them get lost or they get forgotten in the bodies as well. Okay. So in terms of the take-home message, so my take-home message is the risk assessment, of course, is a procedure used to identify and classify health risks in the work environment. It's best performed by a team of people with different expertise. And of course, it is integral to occupational health because it drives actions to control exposure and to monitor exposed workers as well. And of course, as I've tried to show with the example that I've put in, that it is important for you to recognize that as you grow into it and as you do more of them, you become much more refined and much more better at doing the risk assessments. It's very daunting at the start, but I would encourage you to do it with others, particularly those who have done a lot before, and keep doing them, because as you do them, you'll start seeing that you are very different in year one than in year five, because year five you've gotten to see a lot of workplaces, to hear a lot of things, and you become much more comfortable in that as well. Okay, so I will stop there. I had put in just an exercise that you can do on your own of a video of a poultry farm, and just asking you to use this template to conduct a risk assessment based on what the video says. And you can do that yourself, and we will obviously also share the just an example of a memo. But I would advise you do it blindly first, and once you've done it by yourself and completed this, just to get that practice going, then you can look at the model answers which are here. Okay, but let me stop there and take any questions before the next speaker.
Thank you, Doctor. That was so informative and such a detailed assessment. Doctor, I see there's one question in the question and answer section. They ask if there's a difference in conducting a health risk assessment and an OREP, or are the same metrics being used?
Yeah. So with the OREP, the occupational risk exposure profiles, generally with the OREPs, so the risk assessment, I would think of it as a much more broader concept. And from the broader risk assessment concept, you will then have to determine what are you then specifically looking at. So if you are going to be looking at specific tasks and specific individuals, then I would say that goes along the path of the OREP. However, if you are doing a specific area with its specific divisions, so the receiving area, etc., moving until to the dispatch area, that would then be traditionally the higher up form of a risk assessment that one does as well. So they use very similar principles. However, one is, as you can imagine, with the OREP, very much focused on the individual worker themselves. What are they exposed to? What are they expected to do? And very different to focusing on the entire area, for example, an area-based risk assessment. And hence some people would also, just to differentiate, would be quite clear that they use, a workplace risk assessment, just to make it clear that they're talking about the area risk assessment versus the individual one that would be focused on individual. Yeah.
Excellent answer. Thank you so much. Is there any? I'm looking in the chat room. I don't see any other questions. Anyone that wants to raise their hand to ask Dr. another question?
I see Rena was asking, I have a problem with artisans who work all over. Would it be best to do a risk assessment according to occupation? It could be both. So if they're all over and yet they are in different sections which are similar, what you would need to do is, if I could show that again, is to indicate in the areas whether there are artisans there or not. So if I go back here,
Doctor, we can't hear you. Sorry to interrupt.
Hear me now? Can you hear me now?
Yes, Dr. Vetter, thank you.
Sorry, I had to teach the students, so I ran here, and I don't use Teams very often. I normally use Zoom, so I had to just check where all the buttons were to unmute.
Not a problem. We're still busy with the previous speaker. We just
No,
can't
that's
hear him.
great.
So
That's great.
we'll get to you soon. Thank you.
No, I'm in no rush. My students are done. I'm here for you for as long as it takes.
Sure. Dr.
Can I check
Itumeleng?
something with you? Is there somebody speaking after me?
Dr. Julie, the first presenter is still talking.
Oh, I'm sorry. I beg your pardon. When you said you couldn't hear me, I thought.
No, it's fine. It's fine. Dr. Itumeleng, we can't hear you. It looks like we've got problems with the signal. Okay. Is there anything specific that you want to share further? Oh, we can't hear a word. Okay. All right. Thank you so much. It was a very interesting presentation. We will chat with you afterwards. And sorry about the hiccup now. Okay, great. Thank you very much. Dr. Vetter, I'm going to hand over to Dorothy so that she can introduce you.
Okay.
Juanita, this is Adele speaking. I think Dorothy is having issues to unmute herself. So
I can introduce myself.
Yes, we
If
want to
you
say
want.
welcome so much to Dr. Julie Vetter from UCT Radiation Medicine. And then
Yes.
over to you, Dr. Julie.
Yes, so hello everybody, and thank you for having us here. I'm representing our department. So the way it works in Credit Care, and I'm sure in most places, that anything to do with radiation is part of radiation medicine, but it is divided into radiology, which is diagnostic, radiation oncology, which is therapeutic, and then nuclear medicine, which is a combination of diagnostic and therapeutic. So I'm from the radiation oncology department. I'm a radiation oncologist. And as I pointed out to Dorothy, I think we maybe got a little bit the wrong end of the stick when it came to what we were being asked to speak on, because I think you perhaps would have wanted a lot of information on radiation safety in when it comes to industry and so on, and precautions to take. So I can mention a little bit of what we do, but the talk that I generally would give under these circumstances is drawing from my knowledge of cancer and how to treat it and how to treat it safely. So I hope that you will find that interesting. And if you ever need to have detailed information on radiation safety, then I would recommend that we arrange a talk with one of our physicists who generally manage that side of things very thoroughly, and also often have very interesting stories to tell about incidents in industry and so on, where there have been radiation accidents. So just to let you know about that. So I'm going to try and screen share, and hopefully I will be okay with that. Can you tell me whether you can see can you see my screen?
Yes, we can see. Thank you.
And is it filling the whole screen? Just want to check that you can see everything.
Yes, it does.
All right, great. So I just, as I've said already, this is an overview of how we use radiation. I just wanted to check, is there someone speaking after me? Because I just want to watch my time. I'm going to have to speak very fast because this is quite a long talk.
We are just having our meeting after this, doctor, but you can go ahead.
Okay.
We have until 4 o'clock to complete our
All
meeting.
Right. Okay, and so you can see the whole screen, hey, not just part of it. All right. So I'll just go into a bit of, just commentary on what cancer is. So I've chosen to have these rather pretty images of the DNA helix running throughout my talk, because, cancer is a genetic disease. I think when people hear the word genetic, they assume that you got it from your mother or your father. but you can get genetic diseases through spontaneous mutations at any time in your life. And so this is what we would sort of summarize it as. And just to mention that only about 20% of cancers that people experience or develop during their lifetime are inherited. We often think about breast cancers being inherited, but actually it's only 5% of breast cancers that are inherited. The rest of them just occur through exposure to estrogen and probably to an increasingly toxic environment with plastic pseudoestrogens and so on in our environment and in our diet. So 80% of cancers are acquired. Either we smoke too much, or we eat too much, or we drink too much. You can't control, how much estrogen or testosterone you're exposed to, other than to sort of control your reproductive life. So people who never have children or have children very late sometimes are thought to be at increased risk because they have more exposure to estrogen. But that's, not a hard and fast rule, because we often see patients who've had many children who develop breast cancer. So that's just a relative thing. And then, of course, exposure to certain carcinogenic viruses, very important. One can, to a certain extent, protect oneself from that. And then obviously we can definitely decide whether we want to be exposed to UV light and so on. The end result is multiple genetic mutations and loss of normal regulation of the cell cycle, which I'll show you on the next page. And then you just get this uncontrolled growth of cells. Normally, if we cut our cells or any other injury, our body knows exactly when to stop once it's healed that defect. Cancer cells just don't know when to stop. So this is just an example of the cell cycle. You don't have to know anything in detail about it. It's just interesting that all our cells go through this phase. There's the M phase for mitosis, which is when the cells actually divide. But the build up to mitosis consists of all these phases, G1, S, and G2. And at any point in time, the cell might decide to go into the interphase, which is a resting phase. And this is of interest to us as oncologists, because if the tissue that has developed the cancer has a rapid throughput through the cell cycle, they often respond very quickly to chemotherapy and to radiotherapy. But tissues like the prostate, the brain, other nervous tissue, and so on, might only undergo mitosis once every couple of months or years or whatever. And so slow growing tissues often don't show a rapid response to treatment. It doesn't mean they won't respond eventually, but it's not that rapid response. So, that's just an interesting aside. And also to mention that no matter what damage is done to the cell, they will actually only die when they try to divide into two daughter cells, as they're called. So we have different kinds of cancer depending on where they've arisen in our body. You get squamous cell carcinomas, adenocarcinomas. Carcinomas are, most people know the name because it's almost like the Latin version of cancer. And then, of course, we have other tumors, sarcomas, which arise from bone and connective tissue, including blood vessels, tumors of the brain and the nerves, tumors of the lymphatic system, of the bone marrow, leukemia, tumors of pigment-containing cells, and that you can get in the eye or you can get in the skin. And then you also have this whole sort of separate field of tumors that arise in small children and babies. And those, they can even be born with these tumors. Tumors of the retina would come to mind, often inherited from one or both parents, and they are treated differently and they have a different prognosis and are seen as being different from adult tumors. So cancer can spread around the body through the lymphatic system, through the blood, and also can just seed out directly into the pleural cavity, the pericardial cavity. So normally you'll find that the tumor will have been lying next to one of those spaces, and then the cancer cells just seed into it, start producing fluid and filling up those cavities. So, you see people with peritoneal fluid, we call that ascites. They might have it in their pleural cavity and often can cause a lot of symptoms as a result of that. But cancers can spread around the body. And what's very interesting, of course, is that we know that even if you take blood from a patient with cancer, we can now demonstrate circulating tumor cells using modern laboratory techniques. But that doesn't mean that those cells are capable of depositing somewhere and actually developing into these secondary deposits. we know that cancer cells actually have to undergo extra mutations in order to grow away from their source. So there's this constant idea that you've got all these mutations going on throughout. I'm only showing this to you because it's just a way of demonstrating that every country will have a slightly different distribution of the most common cancers compared to the least common cancers, and that will depend on the lifestyle of the people who are living in those countries and what exposure they have to certain carcinogens. We know that smoking is going down in places like the United States and Europe, but we know that smoking is still very common in Mediterranean countries like Spain and Italy and Portugal, although there it's also slowly going down. But we also know that there's a big move from tobacco companies to target countries like Africa to try and balance that loss that they are experiencing in the countries I've mentioned by increasing the number of smokers in other countries. So, this all affects the way people present and what they present with. You'll find that in most countries, however, breast cancer will be the most common cancer in women. It's unfortunately an epidemic. I think the lifetime risk of 1 in 29 in 2001 is a lot lower than that. I mean, I've even seen statistics in some countries where 1 in 8 women will develop breast cancer. So just to mention, cancer in Africa is set to increase. We can see it already in our department. We are seeing more cancers every year. This is due to a high burden of oncogenic viruses in some of our populations. We know that people have migrated from much healthier lifestyles in low middle income countries a couple of decades ago. And then as economic development comes along and you develop what I call the McDonald's or Kentucky Fried Chicken environment or lifestyle, so the diseases that go along with poor diet become much more common. Cancer of the colon, cancer of the pancreas, cancer of the stomach. We also know that our population is aging. We are treating people for all sorts of other diseases like hypertension and cardiac disease, and that they're living longer. And the longer you live, the more likely it is that you're going to have cancer. So just, frightening statistics like women in Africa and in Brazil and other places and India potentially, although their healthcare system has improved a lot, have much higher risk of dying of cancer than in countries like Norway, for example. And we know that I think maybe it's a little bit further out than 2030, which feels as though it's just around the corner. We're going to have much higher cancer burden in developing countries because we don't screen and pick up cancers early. So we already see, and we're going to continue to see cancers that are presenting very late and are incurable and will need palliation and all sorts of other treatment, which is a burden on the healthcare systems, never mind on the patient. And most of the world's cancer resources for treating cancer are found in the developed countries in the world, whereas most of the cancer is found in the developing world. Also, we've got other priorities. We don't only have to treat patients with cancer. We also have to worry about infant and maternal mortality, and we also have lots of infectious diseases like malaria, for example. More people still die of malaria than die of cancer. I'm not sure for how much longer, but that is the case. So what is provided in an oncology department in terms of oncology services? What do I do as an oncologist and the people that I work with? I administer radiotherapy with the help of a lot of other people. I am assisted and I'm unable to work without the assistance of lots of other people. The idea is that we target the treatment safely and effectively. I also give chemotherapy. There are other drugs that we use as well. We sometimes use hormones, manipulate the immune system, use other drugs to treat cancer. And we sometimes use them alone, but more often than not, we use them in combination. We also will treat benign diseases, but you don't need to worry too much about that. It's just an interesting thing to know that radiation is very effective for a lot of benign diseases. We work in multidisciplinary clinics. Where we actually work as a team. We work very closely with the surgeons. Or the primary treatment of choice for most cancers is to first have it cut out and then radiate afterwards. Nowadays, we often radiate first and then operate. The surgeons will then operate and so on. Depending on, the disease, you might need a physician. You definitely need the pathologists always, you radiologists always, nurses always, radiographers always, social workers always. And then with children, we often need also to have specialized social workers, maybe an educational expert who can help the children when they're in hospital for prolonged periods of time. And also we need psychologists, because there are obviously consequences when small children have to go through cancer treatment. And what are we mainly doing? We're mainly doing these decisions all the time. Whether the patient's a new patient or coming back with new symptoms, we have to decide whether we are going to aim for cure or whether we are going to palliate. So when we are curing, we want to get rid of the cancer cells. We want to induce complete remission, as we call it. We don't really cure people. We don't say that, but it's our intention to cure, but actually we're intending to put someone into a complete remission with as little morbidity as possible. So we want as few side effects as possible. We use combination treatments, so radiation and chemotherapy most commonly, but other drugs as well. And this takes a long time. Patients are attached to us and coming in and out of our clinics for weeks to months. And we want to know that we've given that person best chance of survival. If we see that they've presented too late and that this is not possible, we have to be brave, and we have to understand that we have to tell the patient that there's not much we can do other than to make you hopefully suffer less and die, and as you can see, I've written at the bottom here, with dignity. Often we will only use one modality of treatment, very commonly radiotherapy, and we try to make the treatment period very short so that the patient spends more time at home. We're trying to improve quality of life and decrease symptoms. If we make the mistake of deciding that treating a patient with palliation, we'd rather, we can't face, the idea of not helping them as much as we can, you often end up treating yourself rather than the patient, because they end up staying in hospital for most of the time that they have left, and they would rather be spending that time with their family. So you have to be able to make those decisions. So how does radiation actually work in treating cancer? Well, radiation is just part of the electromagnetic spectrum. You can see on the left-hand side, got radio waves, which have a very long wavelength. They're low energy. And on the other side, you have gamma rays. Sorry, this has slipped a little bit. It's meant to be around the gamma rays and the X-rays. These are the sort of energy rays that we use to treat patients. You can see ultraviolet is quite close by. That's part of sunshine. And so we talk about this concept of non-ionizing and ionizing radiation. On the left-hand side is the non-ionizing, and on the right is the ionizing radiation, and I'll go into more detail about that. And you can see here that ultraviolet light, which forms part of sunlight, is sitting on the fence there. And that explains why it can cause so much damage and cause skin cancer. We can only treat cancer with ionizing radiation. There is no curative, treatment with anything less than that. So ionized atoms are highly reactive, which means they have very high energy. They can break the chemical bonds in the DNA helix. And I'll show you a diagram of that. Streams of these ionized, highly active atoms are what we call ionizing radiation. And they can either be X-rays, which is electromagnetic, or they can actually be the particles from the inside of the nucleus of a and so those are electrons and so on. So radiation can be generated by a machine, or it can be released spontaneously by decaying radioactive isotopes. So particle radiation, I've just listed them all here. There's electrons, protons, alpha particles, neutrons, etc., etc., etc. We only generally have access to electrons. We used to have access to protons and neutrons, but the cyclotron out in Somerset West is getting a bit old. I just saw an interesting presentation on using alpha particles in a glue to stick onto the skin to treat superficial skin cancer. So there's lots going on in terms of research in cancer. They all have very specific properties that we can exploit and use to treat different situations, depending on where the cancer is. So as I've already mentioned, X-rays and electrons are created by what we call a linear accelerator. We shorten that to a LINAC. And then you can create protons and neutrons and cyclotrons, and you can actually make radioisotopes in these cyclotrons as well. So this is actually what radiation does to the DNA inside, which is inside every single one of our cells. Okay, so the ionizing radiation is pointed at the tissues of the patient, and inside those tissues, it either interacts with hydrogen and oxygen to form an oxygen-free radical. We all know, there's vitamins and things that you can take that are free radical scavengers, because we know that they cause damage to our tissues. But here we are deliberately creating those oxygen-free radicals, or an electron might get excited out of the out of the atom and actually cause destruction on its own. Either way, the way that we damage cancer cells and normal cells is the radiation is directly damaging the DNA helix. And then when those cells try to divide, as I said earlier on, they will die at that point. And just to point out, you can't just damage one side of the DNA helix. You actually have to damage the opposing gene, because we all have double of everything to protect us. And so you have to actually damage both before you cause a mutation. Just to remember again that radiation is effective for controlling cancer in the curative and the palliative setting, and that up to 50% or even more of patients with cancer will end up having radiotherapy, and we can combine it with chemotherapy, but I've mentioned that already. When we are using it for cure, we can either use it on its own, and that we do quite often, or we might use it after the patient has had their surgery, because now we get the results back and we see that they need to have further treatment, because otherwise it will come back. This is the most common use of radiotherapy. Adjuvant means in addition to or after. Neoadjuvant means beforehand, and this is becoming quite common in treating rectal cancer, sarcomas, where the patient might present with a very bulky tumor. They get a short course of radiation, they get reassessed 6-8 weeks later, and then the surgeons decide if they're then going to have to remove the rectum, or whether they can use other treatment, more chemotherapy and radiotherapy, to maybe get rid of the tumor completely, or just adopt a watch and wait approach. So these are the ways that we can sequence radiation into cancer treatment. When we are palliating, we are just trying to do basic things like reducing the size of a large tumor, because the sheer size of something can often cause a lot of pain and so on. In this way, we're also relieving pain, but sometimes the pain is because of the position of the tumor in the bone, you know, sort of squeezing nerves as they come out of the spinal cord, or in a limb, or in the head and neck area. We often see very advanced tumors bleeding a lot, and we can use radiation very, very effectively. Very low number of treatments. We can even use one treatment of quite a high dose to stop severe bleeding from any of these areas. And also by decreasing swelling around, for example, brain metastases, we can then prevent patients from having epileptic seizures, or even dying from the swelling that these create on the brain. So radiotherapy has many uses and benefits, but it does have potentially lethal side effects, both for the patient as well as for the people administering it. I'll go into a bit more detail. It has to be used with great care. It's 100% driven by technology at the moment. It's exploding exponentially in terms of what is being looked at and done. And AI is obviously a huge thing for us at the moment, and will become so even more so in the future. All our personnel have to be highly trained, not only in terms of using equipment, but also how to use the equipment safely, to look for anything that is amiss and to catch it in time. So I'm just going to speed through this next bit because I am a bit concerned about time. So I'll just show you some very quick pictures, because radiotherapy has been around since the late 1890s. It used to look like this. And these are the people that worked with it. And then in the 1940s, 50s, 60s, 70s, it looked a lot like that, very sort of old-fashioned, as you can see. And then from about the 1970s, when the CT scanner was developed, it started to look a lot more like this. And we can either do external beam treatment, or we can implant isotopes into patients, and it starts to look more modern and more like what we're used to now. We rely completely on computerized planning. We need to scan all the patients. We need doctors, radiographers. You can read through all of that. Everybody has a role to play, sometimes more than once. So the radiographer calls the doctor looks, goes back to the radiographer, and so on. And then eventually the physicist is checking for safety. And then we have treating radiographers who actually administer the treatment. So we now have what's called intensity modulated radiotherapy and rapid arc therapy. I'm going to show you a video quickly, where it has become even more sophisticated. We are able to treat smaller areas to higher doses, and accuracy becomes even more important. So hopefully my video will work. And this is just showing you what a patient looks like getting treatment, modern radiotherapy treatment. You can see how the beam fluence, as we call it, is changing as it moves through the patient. So we are creating areas of high dose and low dose to create the optimal dose distribution. It rotates around the patient once, and then it goes again in the opposite direction, as you can see there. So the whole treatment generally takes place over about 2 to 3 minutes. Setting up the patient takes a bit longer, but this allows us to treat many, many more patients than we ever were able to treat with the old-fashioned way. So when it comes to safety, we have to look at two things: safety of the radiation worker and safety of the patient. So just to remember that radiation causes damage to everything, but by making sure that we don't exceed certain doses to certain tissues, depending on where we are treating the patient, we try to minimize these side effects. And the wonderful thing about cancer cells versus normal cells is that normal tissue, provided you don't exceed this dose, is able to repair itself from the damage caused by the radiation within 6 to 8 hours. We can actually treat people 3 times a day. We can treat them once every 8 hours, and they will still recover from the treatment, provided we don't exceed a certain dose. But the cancer cells are usually not able to repair themselves. And so we are exploiting this difference between cancer cells that grow out of control, but are actually quite weak in many ways and not able to look after themselves the way healthy cells can. Side effects of radiation, I'm not going to go into this in great detail, but we expect everybody to have some side effects during treatment, but they generally will all recover from that, provided we've done our job properly. The late side effects are what we have to be so careful about, because this is not about damage to the actual tissues, it's about damage to the blood supply to those tissues, and that gets worse with time. And they can even, if you know, cause death if it's severe enough. So this is some of the acute radiation reactions, especially common in the head and neck and on the skin. This is a lady who's had a mastectomy, and now she's having radiation to her chest wall, and you can see how pink and inflamed it is, but this will heal. And then here's a patient who's having treatment to the lymph nodes in the neck, probably for a lymphoma, and you can see this very red, angry skin, some blisters and so on. We don't see that anymore with modern radiotherapy, but just to give you an idea of what it did look like. And then these are the late side effects. You can see loss of tissue, one leg shorter than the other, facial malformations, damage to the bone of the mandible. These are all things that have come because the blood supply to these tissues has been damaged. And we can avoid most of it, but we can't avoid all of it. For example, if you radiate the limb of a growing child, you will never be able to avoid the growth arrest that is going to become a consequence of that. So that's just an example. So we try to avoid the late side effects at all costs. And so we are trying to balance complications against tumor control at all times. So just again, to go back to the difference between curative and palliative radiotherapy, with curative treatment, we give a small dose once a day, and we aim to give a large-ish to very large total dose over a long time. So you can imagine why it's not a good idea to do this for someone who's not going to go into remission. And then when it comes to palliation, we give a lower total dose, we give a little bit more per day, and we give it over a shorter period of time, and the patient spends more time at home. And as I mentioned, you can give as little as 1 fraction to improve pain and stop bleeding and so on. So this is how we avoid damage to surrounding tissues. We block the radiation with lead or with this very fancy contraption in the modern linear accelerators. These are lead blocks. And we create these shapes where we are protecting, for example, the brain and the eyes, but we're treating in the middle there. Sometimes we will position patients in specific ways. This is how we treat breast cancer patients. They lie with their arms above their heads, and it allows the beams to come in without interacting with the arm. We're very concerned about how much dose we give to the heart and the lungs for long-term side effects. And we try to do manipulations to keep the small bowel out of the field, for example, as you can see there with the belly board. We're also very accurate with our positioning. If patients are being treated in the head and neck, they actually get immobilized in a cast that's clipped into the bed. We do the same with the body. We try to make sure that the patient can't move around during their treatment. We immobilize their legs. So we try to do all of this so that it's reproducible, and we're placing the radiotherapy every single day in the same place. And then radiation safety for the radiation workers. I just have one slide on this. I just used this example of the DNA helix just to mention that radiation exposure is harmful and dangerous, and that we have to avoid exposure to our staff all the time. So radiation workers have to register in any of the departments where they might be anywhere near radiation. We wear badges every day, and then we hand them in every month. They are then sent to centralized SAPRA where they are read, and we have both monthly and annual radiation limits, which are higher by far compared to the general public, but still obviously safe. We then use these electronic dosimeters in the bottom right hand here. People who are handling radioisotopes directly are meant to do that. So if you're actually doing brachytherapy and you're standing there and you're loading implants and you're physically hanging over them, which is what does sometimes need to be done, you need to wear that during that procedure. And also all our pregnant staff have to wear these electronic monitors every day at work throughout their pregnancy. And then, of course, when we're looking for, maybe we've dropped a radioisotope or something, which heaven forbid that should ever happen. But if we ever need to screen a room or screen a patient to make sure that nothing has been left behind, then we use the good old Geiger counter, as you see over there. And then just a reminder that radiation exposure can be external, and this is what's happening when you are receiving radiation, or whether if you go into a CT scanner room while a patient is being scanned. You can also get contaminated with radioactive particles in that's, dust and so on, as happened in Chernobyl, where the whole area was contaminated and people were actually breathing the dust in which case it would be more internal contamination where it's inhaled or swallowed or drinking contaminated water. So just to remind you of that. And then I'm going to skip over the next one, other than maybe just to show you photographs. So here we are implanting radioactive isotopes into patients. This is absolutely essential for cancer of the cervix. We cannot induce remission in these cancers without brachytherapy. We implant radioactive iridium directly into the cervix with a special applicator done under general anesthetic 4 times during their treatment. And then also to note, we can use it to treat. This is a palate. And this is the tongue at the bottom, and this is the palate 2 years later, because this has been implanted with iodine and it's now gone away. We can use it to treat eye tumors in children and so on. So we do have the ability to do that in this department. We're very lucky. It's a very specialized way of administering radiotherapy to a very, very small area with very little exposure to surrounding tissues. And so in summary, most cancers require multidisciplinary treatment, and radiotherapy is effective for most cancers. And we have to spare critical structures, and that is just as important as giving the correct dose to treat the cancer. So we are balancing our side effects versus our opportunity to cure that cancer. So that was really a very fast whistle-stop tour. I hope it wasn't too fast and that it made sense. And if there's time, people can ask questions. Otherwise, you can send me questions on email or whatever. And as I mentioned, you can ask for a talk by one of our physicists in the future if you would like.
Thank you, Dr. Julie. This was very, very insightful. Thank you for sharing your time and your expertise with us.
It's a pleasure.
Any questions? Anyone want to raise a hand to see if there's any questions? Dorothy typed, thank you, doctor.
Oh, it's a pleasure. I think Debbie Johnson wanted to ask something.
Can you see the question, doctor?
There you go. I'm unmuted, Debbie. She can just unmute herself and then talk. Debbie, you want to unmute?
I think the unmuting, it's not working for people.
Can you hear me?
Yes, I can hear you now, Debbie. Yes.
Good afternoon, everyone, and good afternoon, Dr. Witzer. I just wanted to inquire if medical aids funds brachytherapy and any of the new cancer treatments that is currently available. And just my second question as well, does the newer cancer treatments work much more effectively than the radiation therapy? Thank you.
Okay, so first of all, medical aids, they do cover most cancer treatments when it comes to radiotherapy. So if you are using brachytherapy for a recognized cause, like an eye tumor, it's standard treatment for eye tumors. And the alternative the patient has is to have their whole eye removed, which obviously, then most people aren't going to accept if they have alternatives. So they will fund that. Sometimes you have to write a little motivation if they're not familiar with it or whatever, but they will accept that. When it comes to the newer treatments, I presume, are you talking about the biological agents and the immunotherapy and stuff that's come around in the last sort of, 10, 15 years, which is administered intravenously and so on? Or are you talking about specific modern radiotherapy techniques?
Let me just unmute her again. Sorry. Debbie, you can answer the question. Unmute yourself and answer.
The biological ones specifically?
Yes. So medical aids are tricky when it comes to that. It depends on what type of medical aid you have. So obviously, when you join a medical aid, you do have the option to pay more per month, and then you'll get more should you ever need something. Almost all of them, even under those circumstances where you're paying top premiums, will expect you to pay a co-payment. But they are paying for these drugs, but they will first want to know from the doctor, they will want evidence that it is useful and it's going to make a big difference. And then they will say, okay, depending on what your premiums are, they will then tell you how much you have to do as a co-payment. And for some patients, the co-payments are too high for them. So it just depends on that. But I don't think there's a single medical aid that will just pay outright for those drugs. They are exorbitantly expensive. When it comes to whether they are effective or not, they are certainly effective in certain circumstances. We are still at that phase with these drugs where we start always with new drugs, looking at patients who have nothing else left in terms of treatment. So those trials run for years. You take the people whose options are exhausted. They're now either going to, their disease is going to progress until they die, or they can use this drug, and they enroll patients like that. Then you look at all those results, and then you see it really made a difference. Then you start to look at using it in other circumstances, because now you know it's safe and effective to a certain extent. Now you start combining it with radiotherapy before, after surgery, etc. And then, only then, do you find out what a difference it will make to survival, and then it becomes more mainstream. The exception to that at the moment is melanoma, where they've already at that point where they know that if they add certain of these biologicals to melanoma treatment in high-risk patients, they will improve survival, and more people will not relapse if they have these biologicals than if they don't. So we are kind of sitting at that point where we are working out where do these drugs work in head and neck cancer, in this cancer and that cancer. And I would imagine in 10 to 15 years, they're going to become far more mainstream. And we also know that a lot of them are having their patents will expire in the next 5 years. And then countries like India and China will be able to mass produce them, and they will become much cheaper. So I hope that answers your question.
Thank you, Doctor. I just want to quickly find out if in radiation workers, are there organs that is more sensitive to radiation than others? And what protection do you use?
Okay, so the same organs that we would be anxious about in a patient are the same for the radiation worker. So we generally worry about the eyes a lot because the lenses are very sensitive. So, you can, if you're working with radioisotopes a lot, you can get lead glasses. But what we often do is the people who will assemble these brachytherapy implants, they will work behind a lead glass. And then they wear little monitors on their fingers to monitor how much dose their fingers are getting, because that's the other thing you have to be very careful about. I skipped through it, but those photographs of the people who developed radiation at the end of the 1800s, a lot of them didn't realize that the risks that were associated with radiation, and they got cancers, but they also then lost fingers and they went blind and things like that because they were looking at this stuff all the time. I mean, one of the things that sometimes happens, and I know Marie Curie was, some of these isotopes are very beautiful. They literally glow in the dark. And, they were so fascinated by these things, and they were kind of working with them all the time. And obviously there were consequences to that. So and then what we also worry about is exposure of the thyroid gland. So we wear thyroid shields, and anybody who's doing diagnostic radiology where they are screening is meant to wear a thyroid shield, because the thyroid can be quite sensitive to radiation. And in fact, if you're very young and you have even low doses of exposure, you can, in theory, be at risk of developing thyroid cancer later on in life. And then, of course, we can wear those lead aprons to protect us, other organs. And I find, you know, younger people, obviously, one's very concerned about protecting the ovaries and the testes and so on, because they want to go on and have children, so they don't want exposure to that. Those lead aprons will only work up to a certain point. They certainly don't shield you from therapeutic radiation. So when we treat patients, nobody can be in the room. So what happens when we're treating children is they actually have to be given a general anesthetic every day, because the parent has to leave the room. They have to lie absolutely still, unattended, in the room on their own.
Okay, thank you, Adele. And over to you.
Yes, thank you so much, Doctor. If there's no
Pleasure.
questions, then I say thank you. We value your time. This was very, very interesting.
No, it's a pleasure. And anytime you want to talk about something, I'm always willing.
I'm so glad
It's a pleasure. Okay. Bye then, everyone. Enjoy the rest of your meeting.
Thank you.
Thank you. Goodbye.
Thank you.
Bye-bye.
Goodbye.
Bye. Bye.
So we can go on with the rest of the agenda.
Just a minute. I'm just loading it for you, Adele. So I'm going to get to the correct slide.
So I just want to ask if there's any additions to the agenda. And if there's none, then we can move over to the acceptance of the previous minutes. I've got a correction. I just wanted to point out that 1.7, the February financial figures were in the minutes. So the correction is, I'm going to read it to you, that the savings is standing on 222,392 and 2 cents, and the current account for those minutes is 175.77. That is my correction. Any other corrections of the minutes? If not, can we have two people accepting it, please? Mariana Kluter, thank you. And can you see the name you're net? And let me just quickly see.
Petronella McLean.
Okay, fantastic. Okay, then we go on to the portfolios. I'm first up for the financial report. You want me to share? Or there we go. Thank you so much. There wasn't much changes from the previous one. The only changes basically there by the income. We got a small, just over 5,000 Rand from the members. We get a percentage of the membership from head office. So just over 5,000 came in for income on the members. And then on expenses, it was just our monthly bank charges. And then, yeah, that was a little bit of interest in as well. Nothing else. So the final closing balance is standing on 245,179 and 53 cents. This is obviously now the June. It was the end of June. That was the financial sheet that was prepared. The end of July, we will give you in the next opportunity the financials for this coming month that we're still in. And then I go straight over to marketing.
We just need somebody to accept the financial report. I see Petronella McLean has a question.
Okay. Can you
Peter,
see the question? Can you unmute her? Can you read it?
no, she lowered her hand. Thank you.
So yes, acceptance of financial report. I see Kathleen de Villiers and Petronella McLean. Thank you so much. Okay, the marketing report is very short and sweet. We're running out of time. I just wanted to once again mention the 19 companies that took part as exhibitors on the 14th of May at our National Academic Day. The names are there. They are, some of them are new, but they are mostly have been with us for years. They always support us, and we say thank you for that. And then we move over to the Kaleidoscope. Is scheduled for the 28th of August. I've got 7 companies that already is in a process of paying us. 13 already confirmed they will be there at the academic day. So we're very grateful for that. The venue is the Protea Hotel Tiger Valley. That is the Protea Hotel. As you go to Bellville, towards Bellville, you see the hotel on the N1 on your left-hand side. So our monthly meeting speaker for today was Prismia, but unfortunately they had to cancel because they never had a speaker. And then we also just want to say that we do offer non-profit organizations to participate at no cost, and we are planning to invite the Organ Donor Foundation to see if they will be able to be there at the Kaleidoscope. Yes, and that is basically it from the marketing side. So then we go over to the educational report. Dorothy. I see Beverly has raised her hand. Or was that for to accept? Dorothy, can you unmute?
She said Benita will do the presentation on her behalf. Let me just make Benita a presenter. Okay, and Dorothy will share her presentation as soon as let me just Dorothy, you can throw me off. Sorry people, today Dorothy seems to have inherited all the gremlins. Nothing seems to work in her favor today. Let's move on for a second. Dorothy, when you're ready to share, you are welcome to.
So Benita is then next up with the PR report. There we go, Benita.
Good afternoon, everyone. There is not much from my side. Just a reminder of the end of year member speakers. That will be on the 7th of November at 1 per person. The venue will be confirmed closer to the time. Once we know more or less how much people is attending. And you can contact myself or Beverly if you would want to join us. Then also just a reminder that you need to check regularly the SASOHN WhatsApp, Facebook, and the LinkedIn platforms because all information is given there, and then you will stay updated. But you're welcome to contact the committee members or if you have any inquiries about anything. That's all from my side. Thank you.
There we go. We've got Dr. Julie Sveta with us. So thank you for that, marketing. And then so we go over to the EXCO report, Joanne.
There's nothing new on the EXCO report. I removed that slide for today. I will share it after our next EXCO, which is in August. Then I will share all the new details with you. Beverly?
Beverly?
Sorry.
SASOHN next. So you want to mention the upcoming meeting that SASOHN is going to have?
When is the meeting again? I remember we had the invite, but I haven't received it. I haven't accepted it.
In the first week of August, I think.
All right, wonderful.
For the 11th, I think it's the 11th of August, but it is on a WhatsApp group. It has been shared there.
All right.
So anything on a journal and a newsletter feedback, you and Nate?
The newsletter, sorry, let me just see that I'm unmuted. I've created a newsletter for June. I hope everybody saw it. We still need articles from everybody, from anyone, any article on what you find interesting or just news or whatever you want to share with us. Please feel free to send it to my email. It would really be great if we can add more to our newsletter. The next edition will be in September after the Exco, and then I can share some updates with you from Exco as well. I'm going to share the presentation. It seems like poor Dorothy is having a lot of problems. Dorothy, are you ready to continue? Okay. Let me read this. Okay, Dorothy, we can let that stand over. I see that our time is very limited, and then we can sort out the gremlins before the next meeting. I'm just going to load for Beverly so that she can present her part, and it always lands on the wrong slide. Just hang on a sec. Every time I want to. Dorothy, do you want to present? Can you speak?
Yoni, can you maybe just briefly go through this presentation just to mention the highlights?
Sure. You can move to the next slide, Dorothy. Dorothy, you can move on to the next slide. Okay, the kaleidoscope is on the 28th of August, and the theme is Unstoppable Ergonomics for Any Environment. As Adele said, it is going to happen at the Protea Hotel in Tiger Valley. Wonderful, wonderful venue. We are very excited to host it there. Next slide. This is the health calendar for the month. Women's Day is in there somewhere on the 9th, next Sunday. And Mosquito Day is there. That's interesting. Mosquito Day as well. And next slide. Okay, then for the rest of the year, we've got the kaleidoscope for the 28th of August. And then remember, it's a voting AGM this year on the 16th of September. We will let you know where the venue is. We are trying to organize an awesome venue for you. In the meantime, please fill in the voting forms. We'll post the links on the group again so that you can nominate people to serve on the new committee. And then on the 28th of October, we are planning a very special online webinar for your managers or your health and safety representatives. We'll share that with you as we go along. Thank you, Dorothy. Let me just share my presentation again so that we can hand over to Beverly. It's going to land on the first one again. I just know that. Yeah. I thought so. Just give me a moment to scroll forward. Still need to sort that out. Beverly?
Yeah, I'm here.
You can go.
Good afternoon, everybody. So for social responsibility, our ladies who knit for the babies have continued to do so, and a very big thank you to the knitters. And our second project, it remains the same for this year, the family shelter in Somerset West. And we've collected a huge amount of donations, as you can see in the picture there. at the academic day in May, and they were very happy to receive all the donations. And we will continue to make donations in August for Women's Day. And so at the Kaleidoscope on the 28th of August, we're going to put those boxes out again. So if you want to bring any toiletries for ladies, please feel free to do so. I've already started the collection, and we're inviting you also to bring something on Kaleidoscope Day. Thank you.
Thank you, Beverly. Is there
Pleasure.
any under general communication that we received, Janet?
No, there was no communication. Okay, that brings us to the end of the meeting. Thank you, everybody. And Adele, thank you so much for assisting today. It was a few difficult weeks for me, so I asked Adele and Beverly to assist, and they really did a great job. Thank you very much. Enjoy the rest of your day, and I hope the long weekend comes quickly.
Let me just then say condolences to you on the loss of your father. We are truly, you are in our thoughts.
Oh, thank you, man.
So that's a pleasure of the meeting. Thank you very much, everyone. I see we were at one point 101 people, so I'm so glad everyone managed to get the link sorted out. And then thank you, Janet, for all the help.
Thank you. You're a good team. Have a good day.
Bye-bye.
Goodbye, everyone. Adele, if you can just stay behind quickly, just want to ask something.
Okay, Dorothy said that please register for the breakfast. We've already got one person that actually paid the 150 Rand.
Oh, wow.
Yeah.
That's great. I'm removing people. Oh, they are deleted Beverly. Oh, Benita.
I'm still here.
So yeah, so I removed Benita.
Oh.
Without realizing that I did. Just waiting for everybody to leave. Did you also hear that annoying electronic sound in the background?
No.
I can still hear it now.
Yeah, I wonder if it's on my computer or if everybody could hear it. Very annoying.
It's squeaking.
Yes, that's a good description.
Will we get a recording of the two presentations?
Yes, I will share the recording on the group. It's usually a big one, so I have to load it onto YouTube, and then I can share the link from YouTube. But I will do that as soon. It takes a while, an hour or so after the meeting to become available. So as soon as I get the notification that it's available, I will post it on the group.
I'm just thinking of the minutes.
What about the minutes?
The recording of the...
Oh, yes. Yes.
The two presentations.
Yes, Beverly, Dorothy can share the presentations with you,
okay.
Even if it's just a PDF document.
Yes, that's fine.
Yes, that will help. Okay, thank you, everyone. I really appreciate your help. I'm so sorry that it went so difficult for you today, Dorothy.
Yeah.
Hopefully we can iron out all the problems. But this is how it goes. Every meeting there's something that goes awry, and we just have to roll with it. But you did very well today. Thanks.
Dorothy wrote here, you can only mention the presentations, you don't need to rewrite it. Thank you, no problem. I can, okay, still can't open the mic. I don't know what she means. You can only mention the presentations, you don't need to rewrite it.
Yeah, they usually just give a quick summary of the presentations in the minutes. Yeah.
I'll take the highlights.
Dorothy, you asked, was the presentations good to you? I think the presentations were absolutely wonderful. So
Beautiful.
we need
Yeah.
to thank Dorothy for all her hard work and the extra effort that went into it. And like you say, it's Murphy laws that you now can't unmute yourself because you've done so excellent hard work behind the scenes. Two very good presentations.
Yes, it was excellent.
Mm.
I enjoyed the one about the cancer very much. I must
Yeah.
say, even if it
Mhm.
was not specifically OH related, it was still a very, very interesting and insightful presentation. I would love to hear more of that. And there's a lot of people that say that it was good as well.
She's a very
Sounds
good
like Donald
presenter
Trump
as
now.
well.
Okay, that's it.
Thank you.
Thanks, everybody. You must have a wonderful afternoon. And thank you, Adele.
Bye-bye.
Thank
Goodbye. Bye-bye.
you. Bye.